Three or more ventricular complexes with wide QRS occurring at a rate more than 100 per minute is taken as ventricular tachycardia or VT. Ventricular tachycardia is one of the two common potentially life-threatening serious ventricular arrhythmias, latter being ventricular fibrillation. Ventricular tachycardia lasting more than 30 seconds or requiring termination prior to that due to hemodynamic compromise is called sustained ventricular tachycardia. Shorter spells of ventricular tachycardia are called non-sustained ventricular tachycardia or NSVT. If all the QRS complexes in a VT have same morphology, then it is called monomorphic ventricular tachycardia MMVT. If the QRS morphology is varying, it is called polymorphic ventricular tachycardia PMVT. The classical type of polymorphic VT associated with QT interval prolongation is called Torsades points because it resembles twisting of points in an ECG strip with QRS morphology transitioning slowly from positive to negative and back. Torsades points is an important toxicity of many drugs which prolong the QT interval. Hence, it has been made mandatory to test the effect on QT interval of any new drug before approval is granted by the National Drug Control Agency. Torsades can also occur in the setting of myocardial ischemia, complete heart block, and electrolyte imbalances like hypokalemia and hypomagnesemia. Even though three ventricular ectopics in succession with a rate above 100 per minute qualifies for calling it a non-sustained ventricular tachycardia run, it is often called a salvo of ventricular ectopics. ECG showing VPC salvo. The original meaning of the word salvo is a series of shots fired in rapid sequence from a gun or simultaneously from multiple guns. Isolated VPC seen subsequently. QS complexes are seen in V1 to V3, suggesting a previous myocardial infarction. Ventricular ectopic beats originating from the right ventricular outflow tract is one of the commonest forms of benign ventricular ectopy. But at times, RVOT can be the origin of a ventricular tachycardia, which could be either paroxysms of non-sustained ventricular tachycardia as seen here or sustained ventricular tachycardia. RVOT VT can be induced by exercise and has a left bundle branch block morphology. Wide QRS which is negative in V1 and positive in V6 with inferior axis positive in leads 2, 3 and AVF. ECG showing VT occurring during an exercise test. It is a monomorphic VT with QRS negative in V1 and positive in lead 2 and V5 suggestive of RVOT VT. Monitor screenshot showing frequent runs of non-sustained VT. Inset shows a short segment in more detail. Dissociated P waves are seen very well, indicating the ventricular origin of the tachycardia. P waves are seen before the 6th and the 11th QRS complexes with different PR intervals, indicating that they are dissociated P waves. Here the P waves are of sinus origin and do not get conducted to the ventricles because ventricle is already activated by a faster ventricular rhythm. Retrograde conduction from the ventricle into the AV junction and anterograde conduction from the sinus node gets cancelled off, and this is a form of interference AV dissociation. Torsades points is a French phrase meaning twisting of points. The first publication by Desertine on Torsades points was in 1966. Singular torsade is used when there is only a short run with a single twist of points, while plural is used when there are multiple twists. Torsades points is polymorphic ventricular tachycardia associated with delayed ventricular repolarization in the form of QT prolongation. The ECG illustrates all the features with very wide inverted T waves with gross QT prolongation. Polymorphic ventricular tachycardia with twisting of points is well seen. Middle strip resembles ventricular fibrillation. Giant T wave inversion also indicates the possibility of recent cardiac arrest.
They are also known as post-anoxic T-wave inversion.
Belhassen's VT is idiopathic fascicular ventricular tachycardia originating from the left posterior fascicle. It is responsive to verapamil and is an ablatable VT. It is also known as posterior fascicular tachycardia. Belhassen and associates described a ventricular tachycardia responding to verapamil, unlike the usual ventricular tachycardias which respond to lignocaine. It may be noted that verapamil is conventionally a drug used for treatment of supraventricular rather than ventricular tachycardia. Even though other authors had reported on ventricular tachycardias with relatively narrow QRS complex originating from the posterior fascicle, it was Belhassen and colleagues who suggested this form of ventricular tachycardia as a separate entity. Classical ECG pattern in Belhassen's VT is right bundle branch block pattern with left axis deviation as it originates from the left posterior fascicle. Tachycardia originating from left anterior fascicle has right bundle branch block pattern with right axis deviation, and that originating from the left septal fascicle has right bundle branch block pattern with normal axis. 12-lead ECG of idiopathic fascicular ventricular tachycardia showing classical right bundle branch block pattern with leftward axis morphology suggestive of posterior fascicular origin. References on fascicular ventricular tachycardia. Accelerated idioventricular rhythm or AIVR is spontaneous rhythm originating from the ventricle which is faster than the usual idioventricular rhythm in complete heart block, which has a rate of around 20 to 40 per minute. AIVR typically has a rate just above 100 per minute but is lower than the usual ventricular tachycardia. It is sometimes called as slow VT. AIVR is considered as a classical reperfusion arrhythmia which occurs after successful reperfusion of a coronary occlusion either by thrombolysis or percutaneous coronary intervention. Usually, it is a self-limited arrhythmia and needs no treatment. ECG strips showing accelerated idioventricular rhythm. Regular retrograde P waves are seen in the upper tracing. In the lower tracing, retrograde P waves manifest as slight irregularity in upsloping ST segment. Ventricular fibrillation (VF) is a life-threatening arrhythmia which leads to death unless promptly corrected by electrical defibrillation, direct current or DC shock. In VF, the electrical activity is so disorganized that no ventricular contraction is possible and ventricle remains in a still state of cardiac arrest. Ventricular fibrillation is recognized on the ECG as a highly disorganized electrical activity. Each wave has a different morphology. When multiple simultaneous leads are available, as in this case, the morphology is different between the leads as well. Here it is a coarse ventricular fibrillation.